Hey guys, this is a study session on acid-base balance. Any information that is contained within the study session is for educational purposes only. It's not a recommendation for medical care or any type of guidance for medical treatment. As always, consult with your local physician and follow your local policies, protocols, and procedures. With that being said, this is some education that I'm going to provide today as a tutor. So let's get started. This is acid-base balance. So the first thing we need to talk about is in acid-base balance, what we're really looking at is how water and different things move back and forth. So the first thing to understand is something called osmosis. And so what osmosis is the movement of a pure solvent across a semi-permeable membrane from an area of lower solute, okay, to an area of higher solute concentration. So the key thing to remember in osmosis, it goes from lesser to higher concentration. In diffusion, it is a random movement of a solute, whether it's a gas or a molecule. So important when we're talking about ABGs, arterial blood gases. This is going to definitely deal with diffusion because we're looking at gas in a solution across a semi-permeable membrane from an area of higher concentration to an area of lower concentration. So this goes from high to low. The concentration gradient is the difference between the two concentrations, and that's diffusion. Filtration is a process by which water and a diffusible substance move together across a membrane in response to fluid pressure, moving from an area of higher concentration to an area of lower concentration. And a good example of this is edema, is that once we have too much fluid, it's going to move to an area of lower concentration. And we can see that a lot with patients who have things such as congestive heart failure, those kind of issues. Active transport. Now, active transport requires metabolic activity and energy to move a substance across the cell membrane. It provides assistance to move molecules larger or moving uphill in a harder direction. One of the things we're going to be learning about today is the sodium potassium pump, and the sodium potassium pump works through active transport. And this is very important when we're talking about the cardiac system. So here are a few different reasons for that a provider may order arterial blood gases. Now, this isn't all inclusive. There's tons of different reasons why a provider may order ABGs, but this will get you thinking about some of the reasons why an ABG is being pulled. You can have something known as acute respiratory distress syndrome, also known as ARDS, which is a life-threatening lung injury that causes dangerously low oxygen levels. In respiratory failure, we utilize it to assess how well the lungs are moving oxygen into the blood and removing carbon dioxide. In diabetic ketoacidosis, known as DKA, it is to diagnose and manage the severe complication of diabetes that causes the blood to become acidic. Kidney disorders, conditions such as renal tubular acidosis, can cause an imbalance in blood pH. Severe sepsis, and septic shock. What sepsis used to be called was blood poisoning. It is a dangerous drop in blood pressure following an infection. It requires the assessment of metabolic and respiratory function. After cardiac arrest, to evaluate blood gas characteristics during and after CPR. Another thing that we could be looking at is something called inborn errors of metabolism. This is a rare genetic condition that affects how the body uses food for energy. All kinds of different overdoses and poisonings. We want to evaluate the severity of the poisoning from substances, like carbon monoxide, which you may get in a house fire, or drug overdoses, particularly opioids. Patients that have asthma or COPD, we want to monitor the effectiveness of treatment and check for changes in blood gases during an acute attack or exacerbation. Anytime that a patient is on a mechanical ventilator, we evaluate how well that machine is functioning and we make adjustments. So, in the career that I have, that's one of the things that I utilize quite a bit, or ABGs, is to make adjustments to a ventilator if we have a patient intubated and we put them on life support. With oxygen therapy, we can determine if a patient is receiving the correct amount of supplemental oxygen. Any patients that have shortness of breath, it helps us to identify impaired gas exchange. In neuromuscular disorders, it helps to monitor for potential respiratory failure in conditions like myasthenia gravis or Guillain-Barré syndrome. Patients that suddenly come down with confusion or disorientation, that can be a sign of acidosis or alkalosis, and it's one of the tools that we use to rule that out. Same thing with unusual fatigue. That can also be a metabolic or a respiratory imbalance. Nausea and chronic vomiting may indicate an acid-base disturbance, especially depending on how long they've been having nausea, vomiting, diarrhea. So symptoms of acidosis, these include rapid breathing, fatigue, confusion, and heart arrhythmia. So alkalosis can cause muscle twitching, nausea, and confusion. In patients who have had a near drowning or inhalation injury, it helps us to evaluate the impact on the patient's oxygenation. Patients who have had trauma, including head or neck injuries that affect breathing, can necessitate an ABG, or patients who have had chest trauma, burns. Infants in distress, for newborns who are having trouble breathing, will usually gather an ABG to see what's happening with that. So how was an ABG obtained? Well, the most common method is to get an ABG that gets taken at the radial artery. It's the most common way that we in our emergency department. We can also get it a couple of other different ways, but this is a way that we most commonly get it. Obtaining an ABG is not within the LPN scope of practice. So, in order for us to understand an arterial blood gas, we need to understand three essential ABG values. The first is pH. So pH is basically, you have to think about your body as a big, huge chemistry set. And inside of your body, it has to stay kind of a certain environment that's comfortable for everything to function. Now, the normal pH, an absolute normal pH is 7.4. Now, blood can be between 7.35 and 7.45. The closer it is to 7.35, the more acidic it is. The closer it is to 7.45, the more alkaline that it is. And pH represents the environment in which the cells live. PaCO2. Now, Pa stands for partial pressure, and this is partial pressure of carbon dioxide. The normal value is 35 to 45, and what this represents is the respiratory component of the buffer system. So, we're talking about the buffer system. The buffer system is the way that your body compensates for changes in pH. Now, the fastest way that the body can adjust and make changes in pH is through the respiratory system. And so this is why partial pressure of carbon dioxide is really important. Now, the renal system is the other buffer system, and this has to do with CHO3. We're going to talk about that in just a minute. But always remember that carbon dioxide is an acid. HCO3, bicarb. The normal value is 22 to 26, and it represents the metabolic component in the buffer system. Bicarb is a base, where PaCO2 is acidic, bicarb is an alkaline, and it represents the metabolic component in the buffer system. Now, I said just a second ago that your respiratory system is the fastest way to make changes in the pH. Even though it's faster, it's not as efficient as the other buffer system, which is a metabolic component, which is typically slower, but it's a lot more thorough. So let's understand compensation. So full compensation. So we've got an ABG value, all right? We have to have the following. We have to have a normal pH, an abnormal PaCO2, plus an abnormal HCO3. So what's happening in compensation is the problem is there's an imbalance in the pH, and both the bicarb and the carbon dioxide are working together in order to compensate and to correct the pH. And this is known as full compensation. Partial compensation. In this, we have an abnormal pH, so we'll be able to see that the range is outside of 7.35 to 7.45, but you also have to have an abnormal PaCO2 and an abnormal HCO3, is because both of these buffer systems are trying to work together to compensate and correct the pH, but it's just not enough. So we have partial compensation. In uncompensated, we have an abnormal pH, and you're either going to have one or the other. You're either going to have an abnormal PaCO2 or you're going to have an abnormal HCO3. And so you're going to have one that's going to be normal, one that's going to be abnormal, and you're just going to be coupled with an abnormal pH, and that gets you uncompensated. All right, so let's go through some ABGs, and I want to show you how to utilize the tic-tac-toe method for doing ABGs. All right, so if you notice, I made a little tic-tac-toe board. All right, at the top, I've wrote acid, normal, alkaline, and then I have pH, PaCO2, and HCO3. And so we're going to go through a couple of different lab values, all right, and kind of find out exactly what's going on. So the first one is a pH of 7.33. All right. So is a pH of 7.33, is it? Because the normal pH is 7.35 to 7.45. So 7.33 would fall into pH as an acid. All right. So PaCO2 of 50. All right. So we know that our PaCO2 between 35 and 45 is normal. So if it's above 45, we know that we have more acid than what we need. And so we know that our PaCO2 is 50. So we're going to put that in our little checkbox right there under acid. And the next thing is we're going to look at our bicarb, which is 22. Now that is within range because your bicarb level should be between 22 and 26. We'll put that in the normal category right there. Okay, so now let's take a look and we can figure it out. All right, so we see that the pH is acidic, but it lines up with the respiratory system here. And so this is respiratory acidosis. These both line up. So this is pH is acidic, PaCO2 is acidic. That is on the respiratory side, so this is respiratory acidosis. But we notice that our HCO3 is normal, all right? And so since we have only one system that's trying to compensate, all right, we know that this is going to be respiratory acidosis uncompensated. All right, let's try another one. All right, our next one is a pH of 7.44. So we know we have a pH of 7.35 to 7.45. This falls within the normal pH, 7.35 to 7.45. So our pH is normal. Our PaCO2, which is going to be our respiratory system, that 50 is greater than 35 to 45. And so it's going to be falls into the acid category. Now we have to look at HCO3. HCO3 is 29. 22 to 26 is normal. And so we know that this is falling into the alkaline category. This is a conundrum. And this happens sometimes, all right? So now we have to figure out is because once we see that the pH is in that normal range, we know that this is going to be compensated. All right, it's going to be compensated because we can see that both sides are working together trying to correct the pH. But now we need to figure out which system is involved. All right, so we know that our pH is 7.44, 7.35 to 7.45. So we know that normal pH is a 7.4. So is this tending more towards the alkaline side or more toward the acidic side? In this case, it is more toward the alkaline side, and the alkaline side matches up with the bicarb. This is going to be, what do you guys think? This is metabolic alkalosis fully compensated. All right, let's do a couple more. All right, we have a pH of 7.48. So we know that pH is between 7.35 and 7.45. So this is out of range. And so this is going to be on the alkaline side because it's that higher number there. So we'll go ahead and mark alkaline. Our PaCO2 is 30. All right, so we know that PaCO2 is between 35 and 45. So PaCO2 that is in that we don't have enough of it is going to be alkalytic, is because it's below 35. All right, our HCO3 is 23, and so that is between 22 and 26, so this is normal. All right, so let's take a look here. We know that we have the alkaline matches up with what's going on in the respiratory system. So this is respiratory alkalosis is the first part. Now we need to find out if our respiratory alkalosis is compensated, uncompensated, or partially compensated. And since it only includes one system that's trying to compensate for it, this is uncompensated. This is respiratory alkalosis uncompensated. Let's do one more here. All right, we've got a couple more we can do. pH 7.14, so 7.35 to 7.45, and it's 7.14. This is going to fall into the acid category. All right, so it is definitely acidic. Let's look at our PaCO2. Our PaCO2 is very high at 72. All right. And then let's look at our HCO3, which is 24, which is in between that value of 22 to 26. And so for this one is going to be respiratory, because it's in the respiratory system. Acidosis, these match up, respiratory acidosis. And because only one system is involved in trying to correct it, it is going to be respiratory acidosis uncompensated. All right, last one here, guys. pH is 7.6, so 7.35 to 7.45, and so 7.6 is going to fall way over here in the alkaline category. And let's look at our PaCO2 is at 22. All right, so our PaCO2 here is below 35, so that puts us alkaline. Now our HCO3 is 22. 22 to 26 is normal. All right, so we can see here that we have respiratory alkalosis uncompensated, but let's change things up just a little bit. All right, so what if, all right, our HCO3, instead of it being 22 to 26, maybe our HCO3 was like 16, and it happened to fall here in this category. This would be respiratory alkalosis partially compensated, because we have two systems trying to correct the pH. And that, boys and girls, is a tic-tac-toe method for ABGs. Let's keep going. So now let's talk about isotonic, hypotonic, and hypertonic solutions. So in a hypotonic solution, all right, water is entering the cells. All right, so we have water that is entering the cells in a hypotonic solution. All right, in an isotonic solution, the solution stays exactly where you put it. It's neutral. In a hypertonic solution, all right, is where it actually shrinks the cells when we have water that is coming out of the cell. So water is coming out of the cell in hypertonic. It stays where it's supposed to in an isotonic solution. In a hypotonic solution, water is going into it. So here are some examples of these solutions. A hypotonic solution includes 0.445% normal saline, which is also known as half normal saline, 0.33% normal saline, 0.2% normal saline, and 2.5% dextrose are all hypotonic. And so what these do, a hypotonic solution is puts water in. Isotonic, normal saline, which is known as 0.9%, and lactated ringers are all isotonic. Your hypertonic solutions include 3% normal saline, 5% saline, D5W, and D10. All of these are hypertonic. They actually draw water from the cells. So in an isotonic, again, fluid stays where it's put. It's used in hydration as a volumizer in hypovolemic states. So hypotonic solutions pulls water into cells. Hypertonic pulls water from the cells. So this one goes in, this one goes out. Conditions and symptoms. So let's take a look at a couple of different symptoms that you need to be familiar with. And the first one is respiratory acidosis. So with these patients, they're going to be hypoventilating, all right? So they're not breathing enough. So they'll have shallow respirations. They're going to have hypoxia. In severe cases, they'll have low blood pressure with vasodilation, dyspnea, headache, hyperkalemia, dysrhythmias are also associated. They can have drowsiness, dizziness, disorientation, muscle weakness, hyperflexia, and the causes, of course, are decreased respiratory stimuli, such as an anesthesia and drug overdose, COPD, pneumonia, and atelectasis. In respiratory alkalosis, we can have seizures, deep, rapid breathing, hyperventilation, so we're blowing off way too much acid, tachycardia, decreased or normal blood pressure, hypokalemia, numbness and tingling of the extremities, lethargy and confusion, lightheadedness, nausea, and vomiting. Some of the causes can be things like hyperventilation caused by anxiety, pulmonary embolism or fear, and issues with mechanical ventilation is where we're blowing off too much CO2. In metabolic acidosis, some of the things to think about are a headache, decreased blood pressure, hyperkalemia, muscle twitching, warm flushed skin, nausea, vomiting, decreased muscle tone, decreased reflexes, confusion, increased drowsiness. You can also have in metabolic acidosis, especially in DKA, Kussmaul's respirations. The causes are increased acid production in diabetic ketoacidosis and hypermetabolism. Elimination, which we can have in renal failure, we have decreased elimination, and we can have decreased bicarb production due to dehydration and liver failure, or we can have way too much bicarb elimination due to diarrhea, fistulas, and issues like that. Too much acid and too little bicarb is a main problem here. In metabolic alkalosis, we have confusion, dysrhythmias. We can get tachycardia from decreased potassium, compensatory hypoventilation, and causes is an increase of acids and antacids, administered sodium and bicarbonate. We can get it from prolonged suctioning, vomiting. We can have symptoms of dizziness, increased irritability, nausea, vomiting, diarrhea, increased anxiety, and seizures. One of the big things you can have is tremors, muscle cramps, and the tingling feeling in your fingers and toes. And we can also have a decrease in serum calcium. So the problem here is not enough acid and too much base. So let's take a look here and look at hypernatremia versus hyponatremia. So in hypernatremia, we have too much salt, too much sodium. You know, natremia is sodium. And symptoms here, all the symptoms that have to do with dehydration, increased thirst, dry mouth, fatigue, confusion, muscle weakness, restlessness, muscle twitching, and seizures. Some of the major causes include dehydration, watery diarrhea, diabetes insipidus, and kidney disorders. Now, with low sodium, especially if we deplete our salt, you know, maybe by drinking way too much water, which causes something called water intoxication, can be asymptomatic but could cause nausea, vomiting, weakness, confusion, headache, muscle weakness and cramps, reduced appetite, and in severe cases, seizures. Causes include medications such as diuretics, vomiting, diarrhea, heart failure, liver and kidney disease. And you can also get this by simply drinking too much water. We can also get this by giving too much water when we're doing with IV solutions, for example. So let's look at hypokalemia versus hyperkalemia. And the kalemia basically means potassium. All right. So hypokalemia, which is low potassium, all right, is your body is trying to ditch the potassium. And so things that can cause this are loop diuretics, laxatives, and glucocorticoids, inadequate potassium intake, too much water intake. We talked about that a second ago. Cushing's syndrome and heavy fluid loss, which can be from nasogastric tube, emesis, diarrhea, and even wound drainage. So, our signs and symptoms of a low potassium level is going to cause everything to be slow and low. Good way to remember that are the 7 L's: lethargy, confusion, low, shallow respirations, lethal cardiac dysrhythmias, including ST depression, which is a shallow T wave, or a projecting U wave. Lots of urine. The kidneys are unable to make the urine, so it's going to be really concentrated. Leg cramps and limp muscles. So with hyperkalemia, we have too much potassium in the blood, and so we get the body cared too much about potassium, and so this is a good way to remember that with the mnemonic cared. C is for cellular movement. A is for adrenal insufficiency. R is for renal failure. E is for excessive potassium intake. And D is for drugs such as potassium sparing diuretics, ACE inhibitors, and NSAIDs. So, high potassium levels are very dangerous and could lead to death. And a good way to remember this is DEATH. D is for decreased heart rate. E is for early muscle twitching, which is a late ascending and weakness. A is for arrhythmias. And with hyperkalemia, we get tall T waves and flat P waves, prolonged PR interval and wide QRS complex on the EKG. We can have tummy trouble, which can include a variety of different GI symptoms, including nausea, vomiting, and diarrhea. And H stands for hypotension. Hypocalcemia. The problems with hypocalcemia as well, there's not enough calcium. So with that, with low calcium, some of the ways that we can remember this is called spasmodic, which is an easy way to remember this, is S is for spasm. All right. P is for perioral paresthesia. A is for anxious and irritable. S is for seizures. M is for muscle tone and crease, such as the smooth muscles. O is for orientation impaired and confusion, altered mental status. D is dermatitis. I is impetigo, which is rare and serious in that. C is Chavatsky's sign, which is where you kind of tap on that facial nerve and you can see a spasm in the face. And also cardiomyopathy, which includes long QT interval on the ECG. Hypercalcemia. So with hypercalcemia, we get confusion, muscle weakness, bone pain, kidney stones, arrhythmias, and cardiac arrest, as well as excessive urination. Hypermagnesium. Too much mag. So causes include renal failure and excessive intake. Signs and symptoms include low blood pressure, muscle weakness, absent reflexes, and bradycardia. Hypomagnesia, which is basically when we have not enough magnesium, is our symptoms include what's known as irritability, nystagmus, increased reflexes, muscle cramps, behavioral changes, hypotension, ataxia, tachycardia, tetany, which is going to be associated um, with skin turgor, and convulsions. So here are a few lab values to know. And what you understand about these lab values is that a lot of different organizations and different places you may work for may have different lab values, but these are the ones that you're going to need to know for the exam. These are the ones that we were told to learn, so we're going to go over them. Your renal function panel. The two things that you're going to need to know is your BUN, which is a 10 to 20 milligrams per deciliter, and your creatinine clearance, which is 85 to 135. Your serum chemistry, you need to know that your glucose is between 70 to 100. Sodium is between 135 and 145. Your chloride's 95 to 105. Potassium 3.5 to 5. Calcium 8.5 to 10. And magnesium 1.6 to 2.6. Your complete blood count, known as a CBC, your white blood cell count should be between 4,000 and 10,000. RBC is 4.5 to 5.5. Your hemoglobin should be 12 to 15 in females and 14 to 16 and a half for males. Your hematocrit in females is 37 to 47, and in males is 40 to 50. Your platelets should be between 130,000 to 400,000. Coagulation, this is your bleeding time. Your PT should be between 10 to 14 seconds, and your INR 1 second is normal. Therapeutic is 2 to 3, and 3.5 to 4.5. And this kind of goes along with patients who are on blood thinners, that'll let us know if their blood thinning medication is in a therapeutic level or it's functioning properly, or if it's not. All right, guys. Well, this is the end of it. If get into the book, get into your book, go over all of this stuff about acid-base balance because this is something you're going to need for the rest of your career. Also, get out your acid-base practice review sheet and just go through, learn tic-tac-toe, and just make a little game of trying to figure out, hey, what type of imbalance do I have, and is it compensated, decompensated, or is it partially compensated? So I hope you guys enjoyed this. Thanks for watching. And if you ever need any tutoring, just let me know. Stop by the Trio office and they can get you set up if you're a Trio student. So take care. Have a great weekend.